What up, YouTube? It's me. It's ya boy. Thanks for tuning in. Thanks for watching. This is the first video that I have made for YouTube that is going to be serious and not just for jokes. And we're going to talk about, of course, the ever-present pandemic. And specifically, there's a video that kind of went viral with a young lady who's a nurse practitioner, and she's relating what is going on allegedly in New York per her friend that works there. And I stayed away from this video for a long time, and finally I was convinced to watch it. And so anyway, I'm going to give a little commentary, and it won't be a pure reaction video because I've watched it a couple of times, but we'll talk about it. For anybody who doesn't know me, I guess a brief background: I'm a physician. I graduated medical school about 10 years ago. Spent some time in the Army doing primary care on the operational side of the Army, deployed, etc. Jumped out of planes, went to the field, whatever. Got out of the Army, went to formal residency training in emergency medicine, and since finished, passed my written boards. Now I practice full-time as an emergency medicine physician. So whatever, that's my background. The reason that I wanted to make this video was for a couple of reasons. Number one, I have had people that I have known that I've grown up with, and people that I've known from the military ask me questions about what's going on with this COVID-19, this coronavirus. I see this stuff on the news. Like, what do you think, Doc? I don't know what to think about these people. What do you think? Because, I trust you. I know you're reasonable. And hearing that from people is very humbling, and it's one of the most gratifying things that I could hear. And I don't mean it as a humble brag, but having people say that to me really means a lot. And so I thought, for whatever handful of people out there may, value my opinion, I would put this out there, and maybe it would give some perspective on some of the stuff that's circulating on the internet. The other reason is because a couple of weeks ago, my wife asked me, she said, paraphrasing, "I don't understand how so many of these people can think that this is exaggerated, a hoax, conspiracy, insert whatever. How can people think that?" And I said to her, well, it's easy, because I know a lot of people, and I know it's not exclusive to the South, but that's where I'm from. People I know from back home and people that I've been in the military with who are skeptics by nature, okay? I think all of us can agree that the media is not entirely trustable. We know that they make a living by people watching, so we know that things are going to be sensational for them because they want to reel people in. So, people don't trust the media. I'm not interested in talking politically, but for perspective, a lot of views that I have are probably consistent with like a libertarian outlook. And what I mean by that is I don't always think that more government or big government is the answer. And so a lot of my friends feel that same way. So again, people are just naturally have a healthy level of skepticism. And I can relate to that because in many ways I am that guy. So it does not surprise me when I hear people that I know are good people. Maybe they don't have a formal education in medicine, but they are not unintelligent people, salt of the earth people who are very skeptical about the things that they hear. And so since there's a large part of that within me, I thought maybe me giving some thoughts and commentary on this would maybe reach those people and make some kind of sense to them. So we're going to watch this video. I'm not going to go over all of it because it's long enough. If I did, it would just be way too long. But basically the introduction is this young lady making this video is a nurse practitioner, and she's giving an accounting via her anonymous friend in New York City about how things are going down, so to speak, in New York City. So anyway, let's go ahead and get started.
People are sick, but they don't have to stay sick. They are killing them. They are not helping them. She used the word murder.
Oh,
coming from a nurse.
Kind of a big
going to
claim.
New York City, expecting to help.
I guess maybe we are after some shock value to get people to watch.
Patients are left to rot and die. Her words. She has never seen so much neglect. No one cares. They are cold and they don't care anymore. It's the blind leading the blind.
Okay, so let me stop right there. I am a little bit older now, and when I was younger, I had a whole lot of I had a whole lot of anger and strong opinions, and so I'm not gonna, waste the time of getting pissed off. But this idea that people caring for patients in New York City don't care is as offensive as it is preposterous. To say that people are being murdered, I learned after I watched this video that this young lady is like a social media type person, and so that's largely how she makes her money, I would assume. And so I can understand, maybe not agree with it, kind of these outrageous claims like they're murdering people will get people to watch. And so I'm sure that plays into this, because it boggles my mind when I see videos like this. Like, what compels these people to say these things? Do they believe it 100%, or do they believe it, like 30%, but the rest of it is exaggerated because they, want attention, or it's how they get viewed? I don't know. But the idea that people do not care is offensive. That's hot garbage. Consider the ones that have gotten sick and died from this. The young lady that made the news in New York that didn't have PPE, which we know is a problem, went to work wearing a garbage bag, a trash bag, ultimately got sick and died. So you're telling me that she showed up to work wearing a garbage bag to take care of people because she didn't care? I mean, come on. I have a friend named Ricky from the military, and he's a flight medic. He was with the 160th Special Operations Aviation Regiment. He volunteered, like many have, to go up there for free, making $0, putting himself in harm's way to help people. I have a coworker who's up there with the Army Reserves, took probably, I don't know, like a 60, 70% pay cut to go up there and try and make a difference. I have other colleagues, Dr. Mike, who have gone up there and volunteered for free, not just increased risk for the same amount of money, but we're talking about giving up tens of thousands of dollars to try to make a difference. So the idea that people don't care, I realize there's some shock value here, but it's absolutely ridiculous. And so I would say taking commentary or information from someone like this who's going to say that, either they're saying it and they actually believe it, which is a little bit concerning, or they don't believe it but they're willing to say it for the sake of getting attention, and that kind of tells you about a person also. You know what I'm saying? So it kind of frames everything else that she has to say, unfortunately. But we will continue.
Now, a couple of weeks ago, I was on with some nurse friends of mine, and we were discussing different medications that could be used to potentially help people. Doctors who were reporting around the country that they were using a combination of medications that were helping people. People were not dying when they were on these medications. They were getting better. Those medications are not being used in hospitals in New York City. What is happening?
I assume that she's talking about hydroxychloroquine and azithromycin, which I feel like by now, maybe, I guess, in her defense, maybe she made this video a while back. I feel like that has been thoroughly discussed in the media, and I don't mean this in a condescending way, but for people who are not familiar with medicine, research, medication, treatment, the advancement of science and medicine is not like Barry Sanders moving quickly down the field, aggressively and efficiently adjusting course, okay? It is more like an aircraft carrier that makes slow adjustments because safety is a priority. When you can't sleep at night and you find yourself on Wikipedia, Google Thalomide and look at this medication that was used for nausea in pregnancy in Europe, many years ago, was not used in the United States, and that's not a knock on Europe, but it's an example of why things move slowly. And a study of 40 people or whatever, even a study with a bazillion people, it has to be reproducible. You have to have standards, etc., etc. So anyway, that's been thoroughly discussed in the media. So I will let that go.
What is happening is that they're putting people on nasal cannula. If they require more than 6 liters of nasal cannula, they get intubated, they go on the vent, or they get trached.
I don't even know what she means there. They get intubated, which means they have a breathing tube put down their throat into their trachea, and they get put on a mechanical ventilator, which, with the exception of manually bagging someone, that's how someone with a breathing tube would breathe. Or they get trached, which is like a related but a different thing. A trach is where there's a hole made surgically here for the breathing, but those people are still if you have a respiratory failure and you're on a vent long enough, to prevent complications, they will put in a trach and breathe for you there. But I don't, maybe to someone who's not familiar with it, that doesn't really raise any flags. I don't know what she's talking about when they either get intubated or put on a vent or trached. It's like they're related, but what she's saying doesn't make sense. I think she's I don't know.
If there's not enough vents, they don't get high flow, no non-rebreather, no non-invasive ventilation, no CPAP, no BiPAP. They're on a closed system, the ventilator, versus a CPAP or a BiPAP, for fear that it will spread the virus. Which, by the way, I know a nurse in Florida who was fired for
No.
exposing that about CPAP and BiPAP.
Okay, BiPAP and CPAP are different methods of non-invasive positive pressure ventilation. So you put the mask on, it has positive pressure, so it helps you breathe. Just like people at night with sleep apnea, they have CPAP continuous, whereas BiPAP, the pressure changes with inhalation and exhalation. This is a technology that came around certainly before my time, but it has historically saved a lot of people from needing to be intubated in the right conditions, but by no means is it a magic bullet. And people that do this for a living, people that resuscitate dying people for a living, know that sometimes there are people who are not candidates for BiPAP. Okay, there are contraindications for BiPAP, reasons that it's not safe for patients. You know, I won't go into all that, but in addition to that, some people have just progressed into respiratory failure so far that BiPAP is not going to help them. It's not a conspiracy. It's not a dirty secret. She is not wrong that being mechanically ventilated is a closed system, and so with BiPAP or CPAP, you could potentially be aerosolizing the virus that's being shedded from around the mask. I mean, that is certainly a risk. Have people certainly weighed the pluses and minuses of moving more quickly past that to, mitigate some risk? Well, I mean, that's only common sense. If you're not also thinking about how to protect people in the resuscitation bay, the other nurses and whatnot, and staff and doctors, RTs, then you're, as a leader, you're failing. That has to be considered. There's no calculated conspiracy to kill people by skipping over this magic bullet that has the ability to cure everybody. That's just wrong. It's categorically wrong, and it's a distortion of reality and an exaggeration, and that's being kind.
The patients don't know any better. They don't have family with them. There is no one there with them to advocate for them. So they are scared, and
Because
they give
we're trying to
consent.
protect people that...
The ventilators have high PEEP, high pressure,
Oh boy.
which then causes barotrauma. It causes trauma to the lungs. Dr.
Okay, this is hurting my brain. So, when you're talking about mechanical ventilation, you're talking about multiple variables. Okay, PEEP is positive end expiratory pressure, and I will explain that in a minute, but it is one of many variables. Okay, you're talking about a very complicated, nuanced process of mechanically ventilating somebody. Okay, the variables include but are not limited to the speed of inspiration and expiration, the volume of air going in and out of the lungs, the concentration of oxygen within that air going in and out. In addition to the volume, of course, we know volume is always going to be related to pressure as well, which depends upon compliance of the patient's lungs, how stiff the lungs are. Around the age of 40, who has never smoked, my lungs are different from somebody who is 80 and has smoked, who is different from somebody who is 80 and has not smoked, who is different from somebody who is 80 or whatever age and has not smoked but has worked in a Navy shipyard or whatever. My point is that there are numerous variables involved with mechanically ventilating someone, and so to say that PEEP is causing barotrauma is not just like a gross misrepresentation of what could be happening, but it's not even really like a complete thought. Like in junior high school when you have sentences and you have to like break them down into pieces. It's like a sentence fragment, what she's saying. So I will try to explain briefly what PEEP is. Positive end expiratory pressure. When you're ventilating someone in the lungs, you have all these little balloon-like structures called alveoli, okay? When there's air that goes in, or the patient is breathing in, or the vent is, enabling them to breathe in. Air goes in, and these alveoli expand. They open up. Air goes out, and then they go down again. Air comes in, they open again. Now, they're not 100% all of them opening and closing every time. If you have someone who is critically ill, you need all the alveoli you can get, because inside these alveoli, these spheres, all this surface area inside this hollow sphere is a medium for gas exchange, okay? Oxygen in and carbon dioxide out. So you need these alveoli. So what positive in expiratory pressure is the pressure that the vent has in the alveoli at the end of expiration compared to the outside atmospheric pressure. Okay, basically it's keeping some positive pressure in there so that these alveoli stay open. Okay, it's called recruitment, keeping these things open. And like any of the other many variables in here, how much PEEP you need is going to depend on a lot of circumstances. Okay, but the concept of PEEP is that it is a thing that is helpful for people. And if you could say, can we live in a world where we vent people and we don't have PEEP, or we do have it, of course you would say we want it, because it's another tool, it's another thing that we can use to recruit the alveoli, maximize all the alveoli, keep them open for gas exchange. When she talks about barotrauma to the lungs, again, there's a myriad of variables that's involved with that. If you want to try to simplify it, though, if there's one thing that you relate to barotrauma, it's called the tidal volume. And currently, after there was this enormous, landmark research done regarding acute respiratory distress syndrome years ago, we now currently, in my time, as someone relatively new as a physician, we use smaller tidal volumes than we did in the past. So if you wanted to point a finger at a thing and talk about barotrauma, it wouldn't even be PEEP. It would be tidal volume. But even then, this is something that's very complicated, and I think that she's taking her knowledge of mechanical ventilation, which is perhaps not extensive, and I'm not trying to be mean, but she knows some terminology and some lingo, and she knows some about it, and she uses some of this terminology and throws it out there. And so to people who are not educated formally about all this, and again, I don't mean that as an insult, there's a whole bunch in the world that I'm not educated about, okay, but medicine is what I'm educated about. For people who don't know, it sounds like, oh, PEEP, pressure, they're damaging the lungs. I mean, maybe that makes sense to people, but I think that she has an incomplete understanding of mechanical ventilation, and maybe her understanding is superficial, but it's enabling her to throw out some words out there that some people might find alarming. And if you ask me, well, how can you say that your understanding is beyond hers? Well, objectively, again, not personally, objectively, my training and education in medicine is beyond hers to the tune of tens of thousands of hours. And I have no problem telling you that there are people, pulmonologists, critical care physicians, whose knowledge and experience of mechanical ventilation dwarfs my own. Okay, and that's a pro tip. Part of being a professional and having self-confidence is having no problem identifying other people who have expertise and knowledge that exceeds your own. And there are plenty of those people out there. Believe me, I am not the person that knows the most about mechanical ventilation. But again, she's misrepresenting what could potentially be going on. People have the analogy of chess versus checkers. Okay, like in Training Day, Denzel says, this is chess, Jake, it ain't checkers. Okay, there's checkers, there's chess, and then if you ever watch Star Trek The Next Generation, there's three-dimensional chess where they have the platforms, and she's taking something that's three-dimensional chess and she's trying to distill it down and talk about it in terms of tic-tac-toe as an angle to try to, make her point or sell her idea or whatever, and it's just wrong and irresponsible as well, okay?
The protocol is propofol or some kind of sedation because they're on the ventilator, and IV antibiotics.
People who are ventilated need sedation.
There's no hydroxychloroquine. They're not
We've
using
already
that
discussed
combination
this.
with Zithromax. They're not using zinc, vitamin C, high doses of vitamins A
We've
and D.
already discussed this.
They laugh. This is what she's told me. They laugh at that. She says this is a nightmare. It's out of a horror movie, and I don't want to be a part of this.
Okay, well, you don't have to be a part of it. If it's that bad, you don't have to be a part of it. And the reason, again, that they're not using those things is because they have not been shown legitimately to work. And I'm not hating on people. I understand this thing is scary, and I don't mean that to be demeaning. it's scary for me. I'm afraid. Okay, so when there is a little bit of hope out there, whether it's hydroxychloroquine and azithromycin or remdesivir or this or that, I'm all about it, man. I'm reading about it. I'm hoping that this is the thing, because this pandemic thing is scary. Okay, so I'm not knocking anybody for latching onto these things and saying, man, I hope this is going to be helpful. But there is a difference between speculating that maybe this thing could potentially help when there is a void of evidence to support that. Okay, there is not some conspiracy that people are withholding something to help people. It's just the evidence is not there, and hopefully for most people that has been borne out since she made this video. For folks that are still in this camp where they think that it's like a magical cure that is being withheld, I don't know what to tell those people, I guess.
There are doctors all around the world sounding the alarms. These are the drugs that work. This is the pathophysiology of the disease. This is what's happening.
We've talked about this.
And for some reason, it's not changing. Even though we know, some of us know what's going on.
Some of us.
Nothing is changing on the front lines.
Riddle me this. What is more likely, that people who have devoted their entire lives to helping people, to medicine, to science and research, have not found the magic bullet because it doesn't exist, or that Sara NP YouTube personality knows with certainty what is working, but all these other people can't figure it out? It's like we all know that person that has problems wherever they go, and they never realize that the problem is not with everyone else. The problem is with them. Like, what is the likelihood that you are the sole person that has got all this figured out when all these other people with so much education, passion, drive, and experience and desire to help people, while in the face of their colleagues who are dying from this thing, haven't figured it out? I mean, come on.
They're not going into rooms. So they're running long tubing into the room so that they can manage the tubing from outside of the rooms. So if they're not going into the rooms, that means they're not assessing the patients as frequently as you would be otherwise assessing your patients. They are not doing rapid result tests. You're lucky if you get results in 5 days. Okay, this is coming from my friend who is in New York City right now on assignment.
With dramatic pause and facial expressions. Okay, the testing has been a thing that was not optimal to begin with, and it has progressed and it has gotten faster. So I don't, to air that out as if this is something that's horrible that no one knows about. I mean, we would all like for everything to be faster than it is, but that is a known quantity, that testing was slower in the beginning and it is getting better. I want to talk about this concept of having these long tubes running out of the room because they're not, assessing people and they're leaving them to die. People who, don't work in medicine, that may sound alarming and it may make some sense. And again, people that put out stuff like this, oftentimes they will have a small nugget of truth in there, and that's kind of what propels the entire cell, if you will, of what they're saying. And so I will address that. In the ICU and in critical care units, you have people who are intubated, mechanically ventilated. So they are sedated, otherwise they'll fight against the vent, and you can't efficiently exchange gas. So they're on sedatives, okay, which many times are like a continuous drip, okay, that is controlled in real time in a pump, an infusion, continuous infusion, measured in like micrograms per minute or micrograms per kilogram per minute, or unit of medicine per unit of time. Okay, it's a continuous thing. It's not like you get antibiotics every 6 hours. Okay, it's a continuous thing. The same with many of these patients have dangerously low blood pressure, and we have medications called vasopressive agents or pressors that artificially help prop up the body's blood pressure, cause vasoconstriction. And it's a stopgap measurement. It's not a solution, but it helps people's blood pressure while you continue to treat the underlying cause. Those are also continuous infusions, and they have to be adjusted as people's pressure improves or get worse. Same with sedation. It's an ongoing dynamic process. And so the reason that they have these long tubes running to these pumps and medications is not so that they can leave the patients in there to rot. It's so that they can more quickly adjust these medications for the patient as needed, instead of every time their pressure dips a little bit, they got to put all this stuff on so they can walk into the room, so they can click a couple of buttons on the pump. Okay, having them outside the room would enable them to be able to adjust these medications as needed much more quickly, which is better for the patient. Additionally, in these critical care units, oftentimes doors or walls that separate the patient room from the hallway is all glass. So you're sitting glass here and the patient over there. And granted, you can't do a physical exam like that, but you can stand right here and you can see the patient. And oh, by the way, they're on telemetry, so you can also see heart rate, their heart rhythm. Many of them are on continuous blood pressure monitoring, continuous pulse oximetry, end tidal. So you have all these measurements of how they're doing, and you can see them right on the other side of the glass. So the idea that they're not evaluating their patients is just garbage, and it's insulting. In my opinion, the best nurses in a hospital are in the emergency department and the ICU. So this idea that these nurses in the ICU are not evaluating their patients is hot garbage, and it's offensive. But that is the reason they have the machines out there with this long tubing, is so they can make these quick real-time adjustments without wasting time in which the patient could deteriorate by putting all this stuff on, running in there, beep, 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 increasing the Levophed or whatever, the sedation, the propofol or whatever, and then running out. Anyway.
So nurses are being celebrated as heroes, right? We see how like the fire trucks
Yeah.
and the police are like lining up and practically having these parades and celebrating them as heroes. And don't get me
Okay.
wrong, I'm sure in some
Yeah.
parts of the country and other ICUs, I have friends that are working on the front lines in ICU and they are good nurses. And some of them are heroes. But we have nurses being celebrated as heroes who are killing people. They're not heroes. And they're being brainwashed
That
to
is
think they're doing
ridiculous.
something great just by
She's
going.
trying to give this disclaimer like, oh, well, I know some nurses that are good, but these other ones, and then she's saying awful, terrible
You're a
things.
coward. You're hurting people. You're killing them. You're contributing to the problem.
So she's calling these people a coward, who, again, we discussed that earlier. These people are putting themselves at increased risk. Many of these people are volunteering and working for free and doing the best that they can. These people that she's calling cowards, I could go on forever. Some of these people are dying. We have nurses and doctors out there that are taking care of these patients and are getting sick and they're dying, and she's calling them cowards. It's just really unfortunate. I realize that it creates some, sensationalism, and so people will want to watch her, but it's just absolutely ridiculous, and it's offensive. As a nurse herself, I mean, she should be ashamed of herself. She's talking about other healthcare workers, nurses, doctors, ancillary staff, and it's very unfortunate. It's very unfortunate.
And once these people get intubated, they're being scared into giving consent to be intubated, and then for a lot of them, it's over. And there's nobody going to be held accountable. And there's nobody looking out for them. They are completely by themselves.
The people that are looking out for them are the people who have devoted their entire lives to taking care of people and trying to help people, people who have missed holidays, people who have spent so much time in school, seen a lot of terrible things, endured a lot of hardship, and they do all that. There are other ways to make a living, trust me. So they have done all that because they care enough about taking care of people. Those are the people that are looking out for them. Is it true that family is not being allowed into many of these facilities? Yeah, that's true. I mean, it's a pandemic. It's intended to try to protect people. And people do not get scared into intubation. Intubation, putting people on a vent, is not something that we do just for funsies. If people are being intubated, it's because they're in respiratory failure and they're otherwise going to die. No one is being manipulated into anything. Okay, when intubation is on the table, it's because the choice is either death or go on a vent. And she's correct. There are numbers that show that not a lot of people are doing exceptionally well on the vent. A lot of people are not surviving, but none of them survive if you don't intubate them when they're in respiratory failure. Okay.
Buck the system. Something is wrong in the system. So go against the grain. Request records immediately.
I like this part. Records.
Records, transcripts, immediately.
Transcripts? like transcripts of people's
If there's a
grades,
medication
transcripts
that you
from
want your
college,
loved one to be
transcripts
given,
of phone
report it
conversations.
as an at-home medication and demand that it be continued. That's just a tip from inside the system. If you want a medication to
Tip
be
from
given,
inside the system. Thank you,
you've
Sarah.
got to report that it's an at-home medication and that you demand that it be continued.
Yes, please do that. That is categorically false, and it makes absolutely no sense. It makes absolutely no sense. There's no requirement for someone to show up and say, hey, I take XYZ, and now you have to give it to me. That makes absolutely no sense. Otherwise, Dilaudid is a word that people in medicine know because it's a very strong opiate, and people who are in the demographic where they, that's something that they seek out. Dilaudid is a very, requested thing. And so, according to Sarah, I could just show up at an emergency department with a hangnail and say, well, my home medications include 67.5 buckets of Dilaudid every 3 hours, and now you have to give it to me because that's the law. That's categorically false. And I don't really know what her motivation is in saying that, because she has to know that's not true. So I don't know. Again, it boggles my mind why people behave this way and say some of the things that they do, because there's no truth to that. For people who don't work in the system, they hear that, and that sounds like very inflammatory. Like, ooh, yeah, like this is an inside tip to beat the system, and these people are against me, but now I have a tool to fight back. It's false and it's irresponsible. But I digress.
Do not give consent for intubation if you don't want to be intubated or your loved one to be intubated.
Okay.
Demand non-invasive or less invasive ventilation methods. As soon as you give that consent, you might not come out of it. Now, in some cases, it might be appropriate. We just don't know. We know that it's being
I guess you're
used
the one that knows
inappropriately in a lot of
which cases are appropriate,
and that the ventilators are
and
making
not.
people worse.
Ventilators are not. Ventilators are keeping people from dying. Again, if you're at a point where you need to be intubated, it's because the alternative is death. Here we are at 9 minutes and 59 seconds into the video, and I will agree with her that if you do not want to be intubated, or if your family member does not want to be intubated, you need to let people know. And that is certainly very reasonable in many circumstances. But you need to know that choosing to not be intubated means that, you're likely going to die. I had an attending in residency that would ask people, we're approaching this point where you cannot breathe for yourself, and we're going to have to put a tube down your throat and breathe for you to keep you alive. Is that okay with you? And if they say no, he says, I want you to understand that by saying no, that means that you are okay dying today. And if that's the case, then we support that and we respect that. But you need to know that's what that means by saying that you don't want to be intubated. And that's the truth of it. And there's nothing wrong with saying I don't want to live on a machine, or I don't even want to take a chance on a machine, or if it's my time to go, or my dad said, if it comes down to a shortage of vents, he's like, I've been around long enough, somebody else can have the vent, because that's the type of guy that he is. You can say that, and we respect that. It's respectable to say, I'm ready to go. It's my time. By refusing to be intubated when you're in respiratory failure, which is when people get intubated, that means that you're okay moving on and dying. And so I will agree with her in that. If it's not something that you want, you need to let people know. One could make the argument that, maybe there are things for some people that are worse than dying, and for some people that means being on a vent for, X amount of time, and it's different for everybody. But my point is that certainly that is a valid, respectable outlook to say, I don't want to be on a vent, and if it's my time, then it's my time. But that's what that means when you say that you don't want to be on a vent. That's the video. It's very interesting for me to consider someone like this individual, and I'm not trying to hate on her or make it personal, but many of these things that she's saying, she has to know are not true. And again, I don't know if it's she believes some of these things like 100% that are not true. I find that hard to believe. Maybe she believes some of it, but she knows by extrapolating it, then she comes up with this sensational product. After I saw the video, I learned that this lady is like the social media person who's an anti-vaxxer type person. It boggles my mind. I can spend forever trying to figure out what motivates these people, because I'm sure that she's intelligent, but some of these things that she's saying are just way off. and she did not discuss it in the video, but one thing that I did want to bring up was you hear people say people are dying, but they're not dying from COVID. They're dying from this other thing. And don't you know that the government gives the hospital more money if they code it as COVID? So they're just lying, and they're inflating the numbers and all this. And I'll try to be brief, but I think we can all agree that we collectively were not ready for this pandemic, which, I mean, it's a pandemic. That's kind of how things go. So it was decided that there are places that are being hit hard with this that need more resources that they don't have. So the government decides we're going to allocate resources. If you're going to allocate resources, the whole point is to help with treating people that have COVID-19. So you're going to want to tailor where your money goes accordingly. It would not make sense to give the same amount of money to a tiny rural community hospital that has not seen any cases, to give them the same amount that you're giving somewhere in New York City that's just being ravaged. That would not make any sense. So of course, it's only common sense, guys. This is not breaking news, conspiracy, tinfoil hat stuff. Of course they're going to tailor where the money goes according to who's seeing the most, because that's what the money is for treating patients with COVID-19. So I don't feel that that's like spectacular. Now, is there a chance, is there room for abuse and secondary gain and ulterior motive? I mean, of course there is, but that's virtually every walk of life. Of course there is, but for there to be some large united conspiracy for hospitals to lie about people dying from COVID-19, like, we can't even get groups of people in this country to agree on anything else, and you think that you're going to get people all the way from the top of the organization down through the physicians, down to the ancillary staff, down to the people who are doing coding on a computer for $15 an hour. You think you're going to be able to get all those people to buy in and sacrifice their dignity for the sake of the organization that's paying them like $15 an hour in that example? I'm just being pragmatic. Like, there's no way that you could get that many people in on some kind of organized, concerted conspiracy. Furthermore, let me lay out a hypothetical scenario for you, and maybe this will make sense to people who don't work in medicine. But imagine that you have an elderly person that comes in, and this is aside from COVID-19. You have an elderly person that comes in, they have a urinary tract infection. Then that infection becomes so pronounced that their body is fighting against it in such a way that they get what we call septic. Their blood pressure goes down, they have a fever, their heart rate is up. Things that the body is doing to fight the infection are also having some unfortunate consequences, that are putting the body at risk. So this person has a urine infection. Now they have sepsis. Their blood pressure is so low that they're on these vasopressive agents that we talked about. They go to the ICU. Perhaps they had some chronic renal disease to begin with, but with this infection and with this decreased perfusion, which that is the end point problem with sepsis, is that you're not perfusing the tissues with the oxygen that they need. So now let's say they go into acute renal failure, where the kidneys just completely spiral down. And so with this acute on chronic renal failure, they won't be able to clear and sort out the electrolytes within the body appropriately like a healthy person would be. So let's say that they get hyperkalemic, they have too much potassium. And this is not a far-fetched scenario. I mean, these are things that we deal with on a regular basis in medicine. Infection, sepsis, renal failure, hyperkalemia. So the hyperkalemia, the risk with that is that it can drive you into fatal heart arrhythmias. So maybe this individual now, because of the hyperkalemia, they go into an arrhythmia and they go into cardiac arrest. So they're coded. They're given medications to try to stave off the imbalance in the cellular membrane potential with potassium, because all this at the cellular level is based on electricity, the conduction through the heart, and based on cations and anions and different gradients for them to move back and forth, pumps in the cell wall. Anyway, so this person has arrested because too much potassium drove them into a fatal rhythm. So they're given medications to try to shift the potassium in the body to other places, kind of a stopgap measurement to get that person back and get them dialyzed or find a way to get that potassium out. So they're given, bicarb, they're given calcium, whatever. Return of spontaneous circulation, or ROSC as we call it, is achieved. So now their heart is beating on their own again. But now part of their heart went without adequate perfusion for long enough that their heart no longer pumps and squeezes like it should, and ultimately they go into cardiogenic shock with pump failure, can't perfuse the tissues, the person arrests, and ultimately they expire. So I know that was kind of complicated and long-winded, but looking back, could you say that that person died from cardiogenic shock? Absolutely, because that's what happened at the end. Their heart could no longer squeeze appropriately. Could you say that that person died from an infarction of their heart? Well, yeah, you could, because that happened during the resuscitation while they were being coded. Their heart was not getting adequate oxygen. Could you say that they died from a fatal arrhythmia? You could, because that fatal arrhythmia is what drove them into cardiac arrest. Could you say that they died from hyperkalemia? Yes. Could you say they died from acute on chronic renal failure? Yes. Could you say that they died from sepsis? Yes, absolutely. Could you say that they died from a urinary tract infection? Yes, you could, because that's what started it. It's not as straightforward as, this person dies from this one thing or they die from this other thing. It can be, and I wouldn't even say complicated. This is not a far-fetched scenario, but there's multiple steps in there, and so it would not be incorrect or unethical to say that that person died from, acute renal failure, or to say that they died from sepsis, secondary to urinary infection. So in that way, people say, well, they didn't die from COVID, they died from pneumonia. Well, when people get sick and they die, these things are all interconnected. And in my mind, and I am but a humble ER doctor from the South, if someone contracts COVID-19 and then they subsequently die in that immediate period of illness afterwards, and they would not have died had it not been for contracting COVID-19 from the novel coronavirus, in my mind, I have no problem saying that that person died from COVID-19. Okay? Imagine that someone has a stroke and now they are not able to swallow correctly and efficiently because the part of the brain that was damaged controlled their ability to swallow and move those muscles in tandem how they're supposed to. And so now this person that has trouble swallowing gets some food down the wrong pipe, they aspirate some food product into their lungs, they get aspiration pneumonia, a myriad of other things could happen in the hospital. Ultimately they expire. Someone might say that person died from their stroke, and strokes in and of themselves aren't something that I particularly think of as killing people, but that would not be inaccurate, that would not be unreasonable. And you could see why someone would say that, because it was the stroke that led to the aspiration pneumonia. So again, when people get very ill, it's complicated. There's a lot of things involved. When someone dies in the emergency department, and let's say they came in being actively coded when the coroner asked for a cause of death, but sometimes you don't know, and you say, well, they died from cardiac arrest. And they're like, well, we can't put that. We have to put something. And that's because everyone ultimately dies from cardiac arrest, right? Everyone dies when the heart stops, okay? They're living up until the heart finally stops. So to say people die from cardiac failure, respiratory failure, these things are all related. Multi-organ system failure is the word that we use when people progress down this path and they get very close to the end. But anyway, I wanted to address that because it's only common sense that the government is going to try to allocate this money to help fighting COVID-19 to the places that need help fighting COVID-19. Is there some room for manipulation or secondary gain? Sure, of course there is, always, like with anything else in life. But this idea that people are dying but not from COVID-19, hopefully I presented a picture that maybe would help with some understanding of how these things are not just straightforward as number one or number two. And it was number two, so it wasn't number one. So if they said it was number one, that means that they're lying, and there's a huge conspiracy, and the New World Order is at hand, and the Illuminati created it, and all this other stuff, okay? Anyway, I appreciate you guys watching. Hopefully that made sense to somebody, somewhere. Maybe it was helpful. At a minimum, maybe it's cathartic for me to get some of it off my chest. I appreciate you guys watching. This is the first serious video that I've made on my YouTube channel, Dr. Biscuits. If you like Nike shoes, check out my other videos. I also made a funny video about hospital medicine helping out with the COVID-19 pandemic for the nerds in medicine who would appreciate some doctor humor. All right? Thank you guys. Y'all take care.